Well, hello, everyone. It's my great pleasure to have been invited to speak to you today on antibody drug conjugates in gynecologic cancers. And in particular, I'm going to be talking about targeting HER2, which I'll explain in a moment with antibody drug conjugates. So I'm excited to talk about that. I'm Kathleen Moore. I am the Deputy Director of the Stephenson Cancer Center in Oklahoma City. I'm a GYN oncologist, and I specialize in phase 1 through 3 clinical trials. These are my disclosures. I work with a lot of pharmaceutical companies in my job. And my objectives today are pretty simple. I'm going to talk about targeting HER2, the protein HER2, in ovarian, endometrial, and cervical cancer. So I'm going to talk about. So let's get started. So when we talk about HER2, it sounds new. Because we haven't really been able to effectively utilize this target for a long time, but it's not a new target at all. And some of you, if you've had breast cancer or you know somebody that's had breast cancer or even gastric cancer will have heard the term for breast cancer, triple negative breast cancer. What does that mean? Triple negative breast cancer means it doesn't have hormone receptors and it's HER2 negative. HER2 is a very well-known protein that we target or don't target dependent on its presence in breast cancer and now gastric cancer as well. And we've known about this, if you look at the timeline, since 1998. So HER2 as a target in cancer has been around for a quarter century or more. And I'll show you a little bit more about this as we go, but what have we been talking about when I say HER2? Well, HER2 is a protein. The gene for HER2 is ERBB2. So if you get a Foundation report or a Caris report or a Tempest report, they may talk about ERBB2, ERBB2 amplification. That's the gene. That means there's too many copies of the gene. Or they may talk about the protein, which is measured by immunohistochemistry or IHC for HER2. HER2 is the protein that ERBB2 encodes. And so we measure amplifications and protein expression increasingly to try and figure out which tumors should be considered for HER2 targeting therapy. And so we've known about this for a quarter century. The drugs that we developed a quarter century ago are still in widespread use. There's trastuzumab, and the commercial name for that is Herceptin. There's also a variation of that called pertuzumab or Perjeta. And then there's been others. You can see in blue, the blue boxes are all monoclonal antibodies. So trastuzumab, pertuzumab, margetuximab is one of the newer ones. In yellow boxes are tyrosine kinase inhibitor. These are oral medications that target the protein in a very different way. So it's not an oral version of trastuzumab. It's a totally different drug. So there's lapatinib, neratinib, tucatinib. Those are all drugs that we use in breast cancer. We're starting to study a little bit in GYN cancers. I'm not going to talk too much about those today. And then in pink, you can see the antibody drug conjugates, which is what I'm going to talk about today. And the most I'm going to talk about is trastuzumab deruxtecan, because that's the FDA-approved version. I'll talk a little bit about a drug called trastuzumab emtansine, or Kadcyla. That was the original drug in breast cancer. And then I'll give you a little bit of insight into the drugs that are in clinical trials in development. So these are 3 different mechanisms by which we target HER2, and they're all different. And at some point in the future, we may be using all of them, in sequence, as they're doing in breast cancer for patients with certain levels of HER2 expression. So we'll go through that. So we're just going to start with ovary and kind of just, again, for my theme back, this isn't new. I told you a quarter century ago, we were studying HER2, we developed trastuzumab, and early on, and I have this really nice little editorial by Dr. Shepard highlighted here. It came out last year, and I highlighted in yellow the things that I found surprising when I was reading this, and mainly Dr. Slayman, who is basically the father of HER2 targeting with trastuzumab. We owe a lot of our advancements to him. He's still kind of kicking butt, advancing therapies, but he identified early on that overexpression of HER2 in breast cancer and ovarian cancer early on could be targeted, and we could move this into therapeutic opportunities. So he really went on to develop this, and it first became apparent in breast cancer, and of course the rest is history. But we kind of forgot about it in other gynecologic cancers for like 25 years. And why is that? Well, let's go look at the data. And I'm not going to spend too much time on this, but just so you know, HER2 in breast cancer is defined in an increasingly expanded way. And I'll show you those slides in a minute. But in the day, when you're talking about trastuzumab or Herceptin, HER2 positivity is defined as having HER2 3+, meaning it's a lot. There's a lot of HER2, or 2+ with amplification. And in that setting in breast cancer, that setting of HER2 is kind of what we call a driver of why the tumor is bad. And so targeting it is like the driver of the cancer bus. And it imparts a negative prognosis to those cancers. So if you block that, if you sit on the driver of the cancer bus, you slow the bus down or you stop the bus, which is why trastuzumab and pertuzumab, et cetera, in biomarker selected breast cancer worked really well. And so we tried to replicate this in ovarian cancer. And so I'll show you this studies from 2018, but it's a meta-analysis of many studies. And you can see the dates out on the left-hand side. These are from a long time ago, almost 20 years ago. And I'll remind you that, and I was alive during that time, and a GYN oncologist, we just used to lump all ovarian cancer into one bucket. So if it was epithelial ovarian cancer, high-grade serous, low-grade serous, clear cell, mucinous, all in one bucket. And we just talked about ovarian cancer. So these are from that era. We've learned a lot. But we tried to do these studies to say, all right, well, in ovarian cancer, what does it mean if a tumor has high HER2? Does it correlate with prognosis? Does it identify a tumor that's going to do less well than a tumor without HER2? And so these are a couple of the figures from that particular paper. And the truth is that it wasn't clear, really, at that time, using this sort of lumped incorporation of all tumors together and using breast cancer definitions of HER2 positivity. There was really not a clear signal of whether or not it was prognostic. So that's sort of one of the reasons that people are like, well, I'm not going to look at it anymore. We weren't even testing for HER2 for a long time. So that's changing. And I'm going to come back to this figure again a little bit later in my talk. But we are increasingly wondering if HER2 positivity at some level does impart prognostic significance that we should be paying attention to now that we have more active medications in ovarian cancer. And so I'm showing you this figure, and this is from data in Korea. We're trying to replicate this now in the United States. But let me just take you through what this shows. Hopefully you can see my cursor. So these are what are called Kaplan-Meier curves. A Kaplan-Meier curve includes all patients in a clinical trial or in a data set. And this is survival. So this is overall survival. So every time a patient in this data set dies, it kind of comes down. So you can say on this one on the far left-hand side, by 100 months in this data set, in this data Korea, 50% of the patients who had been diagnosed with ovarian cancer had passed away. So that's how you read a Kaplan-Meier curve. What this particular study was looking at was trying to just look at a cohort of patients, again in Korea, and there are differences across the world, but this is in Korea. And they went back and they stained for HER2, 2+, 3+ versus no HER2 or HER2 1+, which is barely any HER2. And they wanted to see if there was prognostic significance on just how long do you live if you have HER2 positive or HER2 negative ovarian cancer. So what you can see in this is all patients in the cohort. And so teal is the patients that are HER2 tumors are, patients aren't, their tumors are HER2 2 plus or 3 plus. And in the orange are patients whose tumors have no HER2 or maybe 1 plus. And so there does appear to be a split. It's hypothesis generating, meaning we can't say this is definitive evidence, but it does look a little different. So that's interesting. Then the second two panels break out the different types of tumors as we now define them. Because remember, I told you a lot of those old studies lumped all the tumors, different types together. It's hard to interpret them. So now this said, okay, these are all patients with high-grade serous only. So that's important. And then the panel in the middle is those tumors that are high-grade serous and homologous recombination deficient or inclusive of BRCA. So here you see, here's the group of patients with HRD positive tumors or BRCA who are not HER2 expressing. And then in teal are the tumors that are HER2 2 plus 3 plus. So this looks quite a bit different. And then here are the tumors that are HRD test negative, the homologous recombination deficiency test negative. And they don't really have enough that are HER2 positive here. That's why this looks so wonky. So this is a little bit uninterpretable. But this one in the middle is interesting to me. And I want to see data in a US population. And we really need to understand if this is real. And I'll just show you one of the cautions. You kind of look at this and go, well, clearly, you know, patients that are BRCA and are HER2 2 plus, they do worse. And so we should use, you know, our HER2 drugs here. But what we don't know from this data set, which spans many years, whether or not these patients ever got a PARP inhibitor. So maybe the PARP inhibitor fixes all of this. So we don't know that. You can't say anything about we should change treatment. All you can look at from this is to try and get a sense of, does this tell us a group of tumors that are going to be more aggressive and maybe need something else as compared to ones that are HER2 negative? So that's the difference between like being a prognostic biomarker, a biomarker that tells us this is a tumor I'm more worried about. You worry about everything, but this is a tumor that maybe I need to use a combination therapy. This is a tumor that I need to be more aggressive. This is a tumor I'm more worried about versus a predictive biomarker. And I'm going to talk to you about those in a minute that says this is a biomarker that I should use a drug for. And sometimes there's the same, and HER2 may be that, where having HER2 high does mean the tumor acts more aggressively and means I should use a special drug. Sometimes predictive biomarkers are just that. If you have folate, for example, you should use mirvetuximab in a resistant setting, but the folate doesn't really have any impact on prognosis. It is there, it's not there, you know, it doesn't really matter. But if you have it, you should use a drug. So that's a predictive biomarker only. This may be both, which is why we're testing it now in everybody. So we're trying to get a sense of what we're doing. And I'll talk a little bit more about that. HER2, having a HER2 positive ovarian cancer, if you're talking about high-grade serous, we're still figuring out because we haven't been testing for it in a long time. But to be really HER2 high is pretty uncommon in high-grade serous. In other types of cell types, mucinous, clear cell, we see more of it. And now that we're testing more broadly, we are finding like 1 pluses, really low levels, and we're trying to figure out if that matters. Like, should I target that or not? So we're still even figuring out broadly in a high-grade serous, low-grade serous, clear cell, mucinous type of cancer, what's my expectation of finding HER2 at all, 1 plus, 2 plus, 3 plus, and then what does it mean? We're still figuring that out. So we're far behind breast in that way. Be that as it may, we did try to target this in the past, just like breast cancer. When we had breast cancer and it was 3 plus or 2 plus with amplification, you used trastuzumab, it was driving the cancer bus and we stopped the bus. Very important. So we said, all right, we're going to do that in ovarian cancer. And this is Michael Bookman's work, who is one of my mentors. And he said, well, we should do this in ovarian cancer. Let's find all the HER2 expressing, high expressing tumors, 3+ or 2+ with amplification, and we'll access trastuzumab for them. And hopefully it will work. And it didn't work at all. The tumors, the patients that came on, their tumors were already platinum resistant. So maybe that's important, maybe it's not. They were selected. They had to screen 900 patients to find the 95 who were 3+ or 2+ amplified. So that high expressing HER2 level is not very common in our tumors. And when we used trastuzumab alone, the response rate was really low. So you might say, well, maybe that's just this study and it missed it, and we should try it again. Well, this is our colleagues. This is my friend Isabelle Ricard, who led the same, almost the same exact study in Europe at the time. And these were published in the early 2000s. So they ran in the 90s. This is old data. But it was the same. Very few responses with the monoclonal antibody alone. And so when these came out, we kind of lost interest. To be perfectly honest, in HER2, we weren't testing, as I've said. No one was getting tested for HER2 because the drugs we had weren't going to work. Why they didn't work? Probably because in ovarian cancer, unlike breast cancer, it's not driving the cancer bus. You could have HER2, it's there, it's a passenger on the bus. So if I block a passenger, the bus keeps driving. Whereas in breast cancer, it's driving the bus. So sometimes biomarkers mean different things in different tumors, and we have to sort that out. But HER2 high alone with trastuzumab didn't work. So we just haven't paid attention for about 20 years until antibody drug conjugates came around. And now the game has changed. So antibody drug conjugates are still a monoclonal antibody. So trastuzumab, I said, is a monoclonal antibody. Think of it like a Y that targets HER2. It finds it on the surface of a cancer cell, it binds. In breast cancer, that HER2 upregulation is driving the bus. It's signaling the cell to do bad things. And so when the antibody binds to it, it stops its ability to what we call dimerize and then send the signals, and it stops the cancer bus. In ovarian cancer or other cancers, it's there, it may be overexpressed as a protein on the surface, but it's not signaling in the same way to drive the cancer bus. But because it's there, just like other proteins, there's lots of proteins that are on the surface of cancer cells that are either only on the surface of cancer cells or so much more on cancer cells than normal cells that we can target them with these antibody drug conjugates. So it's the same antibody. I called it trastuzumab. The drugs that we're using that are antibody drug conjugates start with trastuzumab. It's the same antibody, but instead of being what we call a naked antibody, it's just the antibody binding and turning off the switch. Here with antibody drug conjugates, it's an antibody and then it's stuck to it. Right now they're chemo, but there's others coming, are these super potent molecules of chemo. Totally dissimilar to anything we use like carboplatin or gemcitabine. They're totally different, really, really potent. You can't give them as free drug to a person because they would probably kill the cancer, but if they got to your normal cells, they would kill those too. It'd be super toxic, maybe lethal. But when we put them on these antibody drug conjugates, while they're circulating in your blood, they're not active. They're not active until they bind to the whatever protein, here HER2. And when they bind, the HER2 basically gives it a hug and brings the whole thing inside the cancer cell where it's more acidic. And in the little acidic pocket that it brings it into, the molecules of chemo pop off and kill the cancer cell and hopefully disperse a little bit like a halo and kill surrounding cancer cells, even if they don't have HER2. That's called bystander effect. And so the rationale here is to deliver highly potent chemotherapy that you couldn't otherwise use in a safer way. And so what this is showing you is that if I were to give these drugs, the one we're going to talk about, trastuzumab deruxtecan, the deruxtecan is the chemo, it's the name of the chemo. It's a topoisomerase 1 inhibitor. If I were to give that drug as free drug, which I could, it exists, my therapeutic window of being efficacious and toxic would be super narrow, like almost not existent, probably non existent. Kind of like when we use topotecan right now, we have to give super low doses because it's really toxic, and then it doesn't work because we can't give enough to make it work. So when we use antibody drug conjugates, we can have a much bigger therapeutic window between that dose that's effective and the dose that's too toxic. And within that window, we can treat patients. That's the ideal. This isn't a magic bullet, though. People think they are. Like you're just delivering the chemo right to the cell, and that's the only place it goes, and it kills the cell, and it's like a magic bullet. Someday we may be there. We're not quite there yet. So we do have, and I'm going to talk about the toxicities. There are toxicities associated with these medications that we have to watch for. They're different than chemo, some of them. But we are able to give much more potent chemotherapies with these conjugates than we otherwise could. So this is just another way to show them. This is what they look like. So this is what an antibody looks like, a Y. And so the antibody is specific to a tumor antigen. The antigen's a protein. And then here's the little linkers that we stick on. I don't do this, of course, the drug companies do. And then the little balls are the chemo. And so you can have a different number of linker and a different type of payload with each of these sorts of drugs. And so they're all very unique from one another. But you can see over here, they bind to the cell surface. They get sucked inside in these like little vacuoles that are acidic. And then the chemo is released, kills the cancer cell, and hopefully kills stuff around it. So that's the goal. Right now, there's a ton of different proteins that are being targeted. There's really two main flavors of chemo on the tail. This is going to evolve, though. But right now, there's mainly two. One are microtubule inhibitors. These are most similar to paclitaxel. So when cells divide, cancer, all of our cells, they have to duplicate the DNA, and then they have to split. So if you remember from biology, when the cell's almost ready to split, it makes a scaffolding down the middle and then assembles it. And then as it splits, it deassembles that scaffolding so the cells can split. So when we target that microtubule, that scaffolding, that's what paclitaxel does, either preventing it from assembling or preventing it from disassembling as the cells split, we can cause cell death. And paclitaxel is one of our most effective drugs for especially platinum-resistant ovarian cancer. But you can only give so much before you cause neuropathy and all of the other toxicities. So there are much more potent microtubule toxins out there. The two main ones that we use are a drug called MMAE, which is an auristatin, and then DM4, that's what's on mirvetuximab, that's called a metazenoid. So there's microtubule toxins, there's a bunch in development. Then the other class are these DNA damaging agents, mainly topoisomerase 1 inhibitors. And there's a bunch of those that I'll talk about. Those are most similar to like topotecan or irinotecan, which we don't use that much in ovary cancer because they don't work real well, again, because we can't give enough without being too toxic. So that's the other class. There's going to be more of these in development, which is exciting, but those are the two main flavors. We're talking today mostly about a drug called trastuzumab deruxtecan. So again, trastuzumab is the antibody that targets HER2. Deruxtecan is the chemo on its tail, which is a topoisomerase 1 inhibitor. We'll talk about some of the other drugs as well to be fair and balanced, but this is the one that we have the most data for. And we have that data from a really cool study, was known as a basket study called Destiny Pan-Tumor. It was led by my friend Funda Merrick-Berenstam from MD Anderson, but it was a global study. So you can see the cohorts, it's a basket study. And so this drug is approved for breast and gastric cancer, has been. So they wanted to know, well, does it work in other tumors that might have some HER2 on their surface? So it had a cohort for uterus cancer, cervix, ovary, bladder. They had an all solids kind of bucket, biliary tract cancer, pancreatic cancer. And patients had to have recurrent cancer for which a therapy with survival expectation wasn't available, or they'd already had it, and their tumor had to have HER2 expression 2+ or 3+, did not require that amplification like we need with trastuzumab alone. So 2+ or 3+, local testing, your pathologist says there's some HER2, and they could come on the study. And then the goal was just to look at how often did the tumors shrink, to get a signal of how well it works. And so there are 3 gynecologic cohorts, which we're very grateful for. They're all very small though. So we have to I'm showing you this data, but keep in mind we're gonna see updated data with more patients in the near future. Right now, that's what we have: 40 patients in each of these cohorts. So you can already tell we need a lot more information, but this was good initial information to have. So 40, 40, 40, you can see that about roughly a little less than a third came on with 3+ HER2 positivity, which is the highest. And then some of them most of them came on with 2+. And a few of them, the pathologist at the home institution said they were 2+ or 3+, but when the slides were reread, now this patient could still come on the study, but the study sponsor looked back and they re-scored everything. There were patients who came on where they said, this is actually 1+, really low, like in 10% of endometrial, 20% of cervix, 12% of ovary. They actually didn't meet eligibility. They were 1+, and a few 10-ish%. They said, this is 0. There's not really HER2 here, but all the patients were allowed to be on the study and get the drug. And what did we find? Well, before I show you what we found, let me just show you what the expected frequency of finding HER2 2+ or 3+ is. So in endometrial cancer, 3+ up to 17%, 2+ up to 40%. So it's pretty common to find it. In cervical cancer, up to 11% 3+, and up to 18% 2+. So 30% is not a small minority. So we are actively screening now cervix. Ovary, 3+ is really uncommon, 5% up to 5%. 2+ you maybe pick up about 18%. So it's up to like 23, 24, 25% have HER2 2+, 3+. So not common, but not rare either, which is why we're testing everyone now to try and find these. I mentioned to you, let's start with ovary. So I mentioned to you just how we say patients' tumors are HER2 positive or not has evolved and will continue to evolve over time. So initially in the days 2.5 decades ago, when trastuzumab was developed, there was basically a 2-category system, just to keep it simple. There was HER2 positive, like I said, 3+ or 2+ with ish, which is amplification. And then everything else was called HER2 negative, even if it was 2+ ish. No amplification or 1+ or 0, it was all just said, these are negative. That is how the initial scoring went. In this era, we want to know if there's any whiff of HER2, you have HER2 positive, like true positives, you have HER2 low, and then you have these ultra lows and zeros. This is the evolution. It's very complex, and this is from breast cancer, but we're starting to adopt this into ovary, endometrial, and cervix as well, because we want to know, number one, does it work in a 1+? And then when I have more than one antibody drug conjugate available, if you're 1+ HER2 and maybe 2+ folate or 2+ TROP2, these are the other proteins. Which one do I pick for you? What does being 1+ tell me about the expectation of the drug working? What does 2+ TROP2 tell me about that drug working? So that we can pick the right drug for each patient. Right now we have this one. And so if you have any bit of HER2, we're using it. In the future, it may really change. I may pick different things based on the biomarkers. So this is going to evolve and get more confusing over time. But that will help patients, so that's okay. We look at efficacy from the Destiny Pan tumor study for ovarian cancer. Remember, these are 40 patients who were mainly resistant, whose tumors were mainly resistant to platinum. The response rate was 45%, which is pretty good. And that includes all of the patients. The patients who, when they looked back at the slides, they said, we don't agree. This is 0 HER2. This is 1 plus HER2 or whatever. All the patients are included. Response rate's 45%. When they pulled out the patients that they agreed were 3 plus, so the highest level of HER2, that's only 11 of the 40 patients. The response rate there was 64%. And then when they pulled out the patients that they agreed whose tumors were 2 plus, that's 19 patients, response rate was about 37%. Put this in framework of what we expect with chemotherapy in this setting. Chemotherapy in this setting has an expected response rate of about 15% in a resistant setting. So you can't make too much of 40 patients of data, but this is a signal that we should develop this more and see if it really does hold up and is superior to other available therapies for our patients. But this was a nice initial signal. And as I'll mention a couple times, because it was so strong, even though the numbers are small in the 3 plus group, this led to FDA approval of this drug for any tumor that has 3 plus at HER2 immunohistochemistry. And the NCCN, which is the kind of a listing of evidence that allows us to access medications, sometimes when they're not FDA approved, the NCCN lists 2 plus and 3 plus for access to this medication in the resistant setting. So we're still working on the big phase 3 studies to prove it, but in the interim, this drug is available for tumors that are HER2 2 plus and 3 plus, which is important. There are additional studies and drugs in development. One is, and they both have funny names. One is IBI 354, and the other is JSKN03. These are both agents being developed in China. And so the data that's been presented to date is entirely out of China. And I don't say that to be disparaging. It's just things can be different in the US and China in terms of response rates. So we have to kind of see. But the things to point out here are that these 2 studies allowed 1 plus and up. So they said you can be anything, any whiff of HER2 you can come on. And the response rates were about the same across 1 plus, 2 plus, 3 plus. Again, very small numbers of patients, 40 and 27. So we have to take this with a little bit of caution, but these very high response rates across all 3 studies are very consistent. Here I'll show you what we call are the waterfall plots, and they look like waterfalls. And the more down columns you have, the better. So what this waterfall plot tells you as a patient is when I look at all the patients, each one of these squares is a CT scan of a patient on this clinical trial. And if the squares go down, it tells you the percent reduction in the sum of the tumors that were there. For example, this kind of pink guy right here maybe had a 25% reduction. This blue square right here had a 40% reduction. This purple square right here, that patient had 100% reduction in their measurable tumors on their CT scan. So what we like to see in early drug development is most patients who are participating having some reduction in their tumor, and very few getting no benefits. Like over here, these 3 patients, their tumor just grew, so they didn't get any benefit. Kind of over here, you can see the same thing. There are maybe 6 patients where there really wasn't any benefit, but everybody else, their tumors got smaller. Those are strong signals that we want to move a medication forward into bigger randomized studies to try and get them approved. We have to do it with some caution, though. I mentioned this earlier, that we don't really know, we don't operate with one biomarker at a time anymore. Like I used to, we had no biomarkers. Now we have more biomarkers. And we have to figure out what the combination of biomarkers mean so we pick the right drug for each patient. And we're not there yet. So this is the study I mentioned earlier from Korea where they looked at this cohort of patients. They're about 200 patients. So again, it's a small cohort. And they looked to see where they found HER2. And what you can see here in their high-grade serous population, 3 plus was only 5% of patients, very consistent with what I showed you. 2 plus they found in about a quarter. So that's not too small. 1 plus about a quarter. Mucinous, though, you do find quite a bit of HER2. Clear cell 45% of their patients had 2+, and that's something I want to know about. So we find more HER2 in non-serous tumors, and we need to start looking. But again, it's not just HER2. How does that balance if you also have a BRCA mutation, or HRD, or other proteins? And then I have to select which thing to do. So this is back to that figure I showed you earlier. They looked at the overlap of HER2 and BRCA. And interestingly, I would have thought if HER2 was a negative prognostic factor, it would live in tumors that weren't BRCA or were not homologous recombination deficient. And in this Korean population, it was the reverse. They found more HER2 in the BRCA and HRD. So we need to figure out in a US population, where does HER2 high live in relation to BRCA, in relation to HRD, and how important is it if it's coexistent with BRCA? Does it make any difference on how well that patient responds to a PARP inhibitor? Because if it doesn't matter, we use a PARP inhibitor. If it does matter and it makes PARPs less effective for some reason, or maybe they're just a bad prognosis and so they're not going to do as well, are we ever comfortable enough to substitute trastuzumab deruxtecan into that space? We're not there yet, but that's what we have to think. What does it mean to have overlapping toxicity or overlapping biomarkers? So that's ovary. Let's look at endometrial cancer. It's kind of a similar story. Endometrial cancer, though, as I told you, HER2 is a little more common, so we have a little more data. We do know more definitively that when HER2 is positive in serous endometrial cancers, it does impart a more aggressive phenotype. So this is data from my friend Britt Erickson from Minnesota, where she looked at stage 1 serous uterine cancers. So this is a subset of uterine cancer, and then said, are they HER2 expressing or not? And those patients whose tumors were HER2 expressing had a higher likelihood of recurrence than those that were not. So that's important data in terms of saying, okay, well, there's a study happening right now that says, okay, if you have stage 1 or even 2 serous tumors, or any tumor that's HER2 high, 3+ or 2+ with amplification, we feel pretty strongly that that means that tumor's more likely to recur. And once recurrent, it's hard to cure. So can we cure it? So there's a study right now incorporating trastuzumab, just like in breast cancer, into these low stage cases, chemo followed by trastuzumab, just like a breast cancer, to see if we can keep those tumors from recurring. So that's a very important study that's ongoing, and we'll get the results at some point in the next few years. We have been studying HER2 positivity in endometrial cancers for a lot longer than we have in breast cancers. And so our traditional positive is this group, and the same I've been talking about, 3+ protein expression or 2+ with this amplification. And that's about 18% of endometrial cancers. If you add in the 2+ that are not amplified, then that brings you up to 27% of all endometrial cancers. And then if 1+'s benefit from this new class of antibody-drug conjugates, that's an additional 17% who may benefit from this. So this is not a small proportion of mainly the higher grade endometrial cancers, the more aggressive ones, but this is a proportion of them that we should be identifying and figuring out if they can benefit from these medications. And it's not just serous, it's uterine carcinosarcomas. Carcinosarcomas are incredibly aggressive, and we've not done a lot to change that until now. We do find HER2 positivity in about 16% of them. And the question is, do these drugs work there? And I'm going to show you that. So remember I told you there's 2 flavors of chemos on the ends of these antibody-drug conjugates. There's the microtubule toxins and then the deruxtecan, the topoisomerase 1 DNA damaging ones. The first drugs to be developed were the microtubule toxins. So this is trastuzumab emtansine. So targets HER2 but has a microtubule toxin payload. And these are relatively old studies. We studied this in endometrial in amplified tumors only. And in red are the endometrial cases. It didn't work very well. So we were kind of sad about that. So we were expecting it to work pretty well in breast. Didn't work for us. We did another study, tried it again. We're like, well, maybe there's just small numbers and we'll try it again. So we tried it again, and this was also an amplified, all types of cancers, but the endometrial ones were pulled out. And you can see them here. This is the waterfall plot. This looks different than those other ones, doesn't it? Where most of the patients got benefit. Here it's kind of half and half, where you see, this group of patients had some reduction in their tumor size. This group of 5 or 6 patients were the only ones that hit official response rate. So there were patients who benefited, just not as many as we would have liked. So we were kind of plus minus on this medication. I show you this, I don't want to spend too much time on it, but just the biomarkers and the evolution of the biomarkers are going to be really important to taking really good care of patients moving forward. And do they change over time? If I give you something, when the tumor comes back, is it a different cancer and I need to do something else? This is a question we're starting to face. In this particular study I just showed you, did biopsies at the time of progression, because patients were gracious enough to allow that. It's a big ask. And there's not enough data yet to say anything. But this patient's very interesting. Endometrial cancer, when she came on the study, was 3+, so high. Did really well, had a complete response to the therapy and stayed on for like 18 months and then progressed and was still 3+ at that time. So it's not loss of the protein that made that tumor resistant to this drug. Some other mechanism is in play, and understanding that is going to be critical for us picking the next best therapy for each patient. And how we do that with or without biopsies is something we're actually really trying to understand, because otherwise we're guessing. We don't like to guess, and you don't want us to guess. But these are the types of studies that help us get it there, although it's a really big ask. So those are the microtubule toxin antibody drug conjugate data, just a little bit. Back to trastuzumab deruxtecan, the study from Destiny Pantumor. I just want to show you the differences. They're both the same antibody, trastuzumab. This has a microtubule toxin. This has that deruxtecan payload. They have a different number of chemos stuck to them. So this one has 3.5 molecules of the microtubule toxin. This one has 8. That probably it's probably not important to how well they work. It's just the makeup of the antibody drug conjugate, but they're different in more ways than just the type of chemo on their tail. So how did this perform in an endometrial population? And we already went through kind of the rates of positivity. Well, not surprisingly, it worked very well. 40 patients, so we have to be cautious. Here's all the patients who came on based on their local pathologist scoring the tumor 2+ or 3+, almost a 60% response rate. I will tell you the benchmark for response to any kind of therapy in a second and third metastatic setting in uterus cancer is about 15%, similar to ovary. It's not very good. So any kind of signal like this gets our antennas up. For tumors that were 3+ on central reread, it's only 13 of the 40 patients. Response rate was 85%. Okay, well, that gets my attention. For those that were centrally confirmed 2+, 47%. But look at this, even amongst when a local pathologist said, yeah, I see some HER2, and the central expert pathologist is like, I don't agree. It's 1 or 0. You still saw responses. So it just tells you how little we know about how to really select these tumors, and we need more data, because all of these patients, you could argue, got some benefit. But we do see some differences, because the response rate's one thing. I do want to shrink your tumors, but I want to shrink it, and I want it to stay shrunk for as long as possible. That's a time to event endpoint. If something shrinks and then it just grows the next CT, that's not worth it. I want to shrink stuff and then keep it shrunk for a long, long time. And so that's what these lines kind of tell you. So this is the progression-free survival and the overall survival curves for the patients who participated on the study, all of them. Here are those who are 3+. You can see there seems to be a different versus those that are 2+. Again, coming back to the point that if I don't have anything else in the space right now, and your tumor is HER2 1+, I'm going to try and get you this drug. It'll be off label. In the near future, we're going to have a lot of these classes of drugs with different proteins. And so then it's going to come down to, yeah, I know you got a little HER2, but maybe I have a different drug and I might pick differently. That is coming in the near term, which is very good. Trastuzumab deruxtecan is not the only game in town. I forgot to put the actual name. This is called trastuzumab pamritecan, TPAM. So this is the data that's publicly available. You'll see more coming out in the near future. This is a similar, but a little different chemo on its tail than a deruxtecan, looking about the same. So just to be fair and balanced, this drug did get FDA breakthrough designation and is in a clinical trial moving forward in a randomized fashion. And I mentioned carcinosarcomas a bit ago, which are excluded from a lot of clinical trials, which is very unfortunate. But this study was called the STATUS study, and they went only for uterine carcinosarcomas. They were like, we just want those, any HER2, and we're going to use trastuzumab deruxtecan. We want to see how well it works. And it worked really well. So this is the HER2 traditional high, response rate 55%. And this is the HER2 lows, the 1+s. Response rate 70%. It's small numbers, but almost all these patients had benefit and with tumor shrinkage, and that's what you want. And that really unleashed this testing, fever around all of our patients with uterine cancer to try and find these and make sure they get access to this medication. And this is really in keeping with what they saw in breast cancer. This is HER2 low breast cancer. Now this is approved. I mean, that's why we got the idea, or these guys got the idea to do the study, because it doesn't, efficacy, yes, no, doesn't appear tied to the amount of HER2. The amount of benefit is related, but benefit, yes, no, seems less tied. And that's really what we're trying, to figure out. And this was the ongoing study in the second line space. This is led by Flor Bacchus of trastuzumab pamritecan. This is just getting activated 1+ and up, bringing a HER2 targeting antibody drug conjugate into endometrial cancer. I'm going to end with cervical cancer because I think cervical cancer gets forgotten a lot. But HER2 has always been important here. We don't, again, just like everything else, we haven't been testing for a long time, everybody, and now we're going to catch up with what we think the actual rates are. For a long time, we thought this was just something you find in adenocarcinomas of the cervix. Cervix comes in a lot of flavors, but the two main ones are squamous cell and adeno. It's like a skin type and a gland type. And the gland type we thought had more, and it's probably true, has more HER2 high. So we never tested squamous for HER2, but we are finding it. And so now we're testing them. These are the rates you can kind of see right here for cervix. It's probably about 24% overall have some HER2 positivity. And what happens if we use trastuzumab deruxtecan? Well, again, it works. And so you can see all comers, 50% response rate, which is 5 times higher than anything we see with standard of care medications. If you're 3+, which is very uncommon, 75%, 2+, 40%. So this is why the FDA approved for 3+ and NCCN lists for 2+ and 3+, because we want to test and we want to get these drugs available for our patients while we're sorting out all of the biomarkers. So I've given a lot of positive things. What's the downside? Well, there are side effects, and these side effects can affect, they're different than chemo. There's some overlapping, but there's some things that are different. So I just want to take you through what we think about with me. This is all trastuzumab deruxtecan, because that's where we have the most data. So the things that are similar is we do see nausea and vomiting with this class of medications. It's very, very common. You can see right here, about 56% of patients have some nausea. It tends to be very mild and, well, it can be terrible. It tends to be mild if we use good pre-medications. If we use good pre-medications, just like chemo, patients actually do quite well. But even with that, you can see mild nausea. And so it's just important to tell people that. So they have their rescue medications at home and they take them as needed, because this is common. So we do see it's a class effect of all these ADCs with these topoisomerase payloads, and trastuzumab deruxtecan is no exception. Because it's FDA approved in breast, we have tons of guidelines on how to prophylax. And then if our prophylaxis fails to control symptoms, we have very clear guidelines on how to mitigate further that work really well. So these are very established, and medical oncologists, GYN oncologists know this well. We should be able to adequately control nausea with this medication. And these are just those guidelines. We do see hematologic toxicities with these drugs, and so we have to pay attention. Not a ton with TDX, with trastuzumab deruxtecan, but you can. And so it's driven by the payload, which is a topoisomerase 1 inhibitor. You'll see, the most common high-grade toxicity is white cell drop, which is neutropenia. In about a third of cases, 20% in breast cancer, that they usually have had less chemotherapy than our patients when they're getting this. And we know how to manage this. We have to hold till it resolves. And sometimes we will use growth factors, just like chemo, to help prevent someone's white count from dropping too much if they've either had that happen in a prior regimen, or if they have these risk factors. If they're older, you're older, there's pre-existing. If we know every time you get chemo, your counts just plummet, we're going to use it up front because we don't want people's counts, to plummet. So we'll use these prophylactic growth factors, which I know cause bone pain, but they can protect us from having big drops in white count. Infusion-related reactions, like allergic reactions to trastuzumab deruxtecan, is pretty uncommon, but it can happen. It's an antibody. They tend to be mild, like redness or itching, and we typically just hold the drug, give some Benadryl, and we keep treating. But it can happen, and so if you're getting trastuzumab deruxtecan and you're like, I'm itchy or my palms are red, you want to ring the little bell next to you. But they don't tend to be like carbo reactions where people are emergency ER, to the hospital. But they can happen, so I want you to know that. There's a low risk, it's like 4% of causing heart failure. So we watch echoes when you're on trastuzumab deruxtecan every 2 to 3 cycles, just to make sure we're paying attention. That's more a function of trastuzumab, the older drug. We don't see it as much with trastuzumab deruxtecan, but we do see it 4%. And so we keep an eye on echoes just to make sure your hearts are okay. The biggest thing that we worry about with trastuzumab deruxtecan is pneumonitis, which is thickening of the lungs. It's not common, but it can be lethal, if missed. And so this is the thing that we have our antennas up about all the time. Across all of this is even all, but across several of the studies of trastuzumab deruxtecan and raludotatug deruxtecan, which is also a deruxtecan payload, you can see the rate. I would say the rate's about 14% having any pneumonitis, and the vast majority is asymptomatic. Like, you don't know you have it, and we see something called ground glass opacity or some other infiltrate on the chest CT, and we're like, I have to hold you while we figure this out. And you're going to be mad because the drug's working, and you don't want to hold because you feel good, you're not short of breath, and your O2 sat is fine. You're like, no. But we have to hold and work it up because we can reverse it. But if we treat through it, sometimes nothing happens, but sometimes things can get bad fast and we can't rescue. So we take it very seriously. We screen, we watch CT chest all the time. We don't ever not get a chest CT. Yeah, those days are over. So that's just the screening part. If we detect something, we have to get pulmonology involved to help us. And sometimes we'll hold to work it up, which will make you mad. And then sometimes we'll use steroids to make it go away so that we can restart the medication. This is tricky. I just want you to know what your physician's sort of dealing with, because you'll want the drug and we'll look at your baseline CT, and there's always something on the CT. There's always something, because CTs are really specific now. They'll say something. Inflammatory, something clinically correlate. And I used to be like, how you feel? And patients like, I feel fine. I'm like, great. Can't do that anymore. Like, if I see something, and even if it's something benign, I need someone to look at it and tell me it's not baseline pneumonitis, like from a prior immune checkpoint inhibitor. Because we find there's something on something on my CT scan that's abnormal, and I don't have cancer that I know of. So it's really tricky to make sure we're figuring out baseline what everyone's status is, because these things that we find at baseline some proportion of them could predict a risk of pneumonitis, but most of it means nothing. And we have to sort through that to keep you safe by not holding a drug that is not causing any problems and holding a drug that is causing problems. So it is an area where we get a little crazy trying to make sure we're doing the right thing, for our patients. We really have to involve pulmonology. Like, we're going to send you to pulmonologists. They're going to do pulmonary function tests sometimes, which is annoying. They may want to do a bronchoscopy. This doesn't happen a lot, 14% of the time, but it can happen. And it's annoying to you, but we're doing it to try and make sure we protect you and we know what's going on. And we treat it really aggressively so you can go back on the drug. So grade 1 pneumonitis means you feel fine and I just see something on CT scan. Grade 2 pneumonitis could be anything from, you're like, I feel great, but I have a little annoying cough, or I was a little short of breath, or whatever. That's new for me. Or really short of breath and wheezing. That's grade 2, any symptoms. And I'm not telling you that because I want you to hide symptoms. We must know, but it's a spectrum. Grade 3, severe symptoms, like your O2 sats dropping, and we don't want people to ever get to that point. If we suspect it, we have to do imaging and get it worked up, as I've mentioned. If it's grade 1 and we get rid of it, we can restart the drug. Right now, the package insert by the FDA for grade 2, meaning any symptoms, we have to permanently discontinue T-DXd, which is why we're really conservative if we see anything on a scan before you're symptomatic to hold and get rid of it, because we don't want to be in a position of someone having a mild cough and we have to say, I can't give you this drug anymore. But there were deaths when people were treated through it. So that's why we're so conservative about use of steroids and appropriate workup. People always ask, can you restart me? What if I get this? Can I restart? And we have pretty good data now from grade 1, meaning asymptomatic, that when patients have been appropriately taken care of, we can restart them. And a lot of times without even modifying the dose, and patients do really pretty well. This was a recent study by Hope Rugo, who's brilliant in all things breast cancer, Dr. Rugo, and about 70% of patients who are rechallenged after grade 1 pneumonitis had no problem. And if they did recur, they were very low grade and we could rescue them and then you just didn't try again. So that seems safe. Grade 1 with care, we can rechallenge. Grade 2 symptomatic, we thus far do not have evidence that we can rechallenge. And so the answer there is no. But that's kind of, and I don't want to scare you because ILD is only 14% and we catch it early. And most patients don't ever have to deal with it. But this is the thing that sort of we lose sleep about with trastuzumab deruxtecan, is making sure we keep you safe while we're using it. So in conclusion, I would say HER2 targeting antibody-drug conjugates are very active across gynecologic cancers and are currently available, as I mentioned, FDA and NCCN. We are very focused on optimizing understanding of the biomarkers so that we screen everyone and we select the right tumors, patients with the right tumors for this drug versus other drugs moving forward. Right drug, right patient, right time. We're actually in that era. And education is really, really key for both physicians and patients around recognizing the side effects that can happen with this and every other antibody-drug conjugate under development. So you let us know if you're experiencing something early on so we can mitigate successfully, keep you safe with high quality of life for as long as possible on these medications without severe side effects. So education goes definitely both ways. And with that, I thank you for your attention. I hope you found this not too overwhelming, and I'd be happy to take questions. Thanks.